Okay, we'll be talking about the male urogenital triangle and the male reproductive organs this afternoon. No? This will take approximately around 45 minutes again. So if I'm going too fast, you can message again in the chat box. Sabihan nyo na ako mabilis masyado. Okay? So we'll start. Okay na? Are we good? Are we all good? We have 101.
Yes, Doc.
Kung na naghintayin siguro, no? Okay na tayo. Okay, so let's start. Can you see the PowerPoint clearly? Can you see PowerPoint okay? All right, good.
Opo.
Okay, let's start. So, the male urogenital triangle and the male reproductive organs. Di ba you had your lecture already yesterday? Mag-lecture pala kamo tomorrow? The female reproductive organs, the female triangle. Tama ba?
Opo, tomorrow pa po.
It's the first, I'm the first to tackle the urogenital triangle. So my part would be on the male reproductive organs and the male urogenital triangle. So the urogenital triangle is in the perineum. No? The perineum is a diamond-shaped space at the lower end of the trunk, no, of your body, and it lies between your thighs. Now it lies below the pelvic diaphragm, and it's the most inferior part of the pelvic outlet. So this is the space of your perineum. No? This is the bony structure, your space of the perineum. Now the margins or the boundaries of your perineum are composed of the pubic symphysis anteriorly, the coccyx and sacrum posteriorly. Its anterolateral margins are made of the ischiopubic ramus, no, or the bony part, and the posterolateral portion is made up of sacrotuberous ligament. No? Now, if you draw a line, an imaginary line between the two ischial tuberosities, you will produce two triangles. No, you will divide the perineum into two triangles. You have your urogenital triangle and your anal triangle. No. Now, for purposes of discussion for this afternoon, we will only tackle the urogenital triangle, no, specifically of that of the male, because the anal triangle will be discussed when we talk about the digestive system. Because the anal triangle, most of the mga intestines ang laman noon. Okay. Now, in the urogenital triangle, we have a superficial fascia first. No, the superficial fascia is divided into the fatty layer and the membranous layer. The fatty layer is also called as the fascia of Camper, is continuous with the superficial fascia of the thigh and the scrotum. No? So when it reaches the scrotum, the fatty layer, the fat becomes muscle. No? It becomes a smooth muscle known as the dartus muscle. This muscle contracts in response to cold to reduce the surface area. No? So umuurong siya, when it's cold. No? No, the guys can attest to this. Okay? So membranous layers naman of the superficial fascia is known as the collis fascia. It is continuous naman upwardly with the membranous layer of the superficial fascia of the anterior abdominal wall. The anterior abdominal wall fascia is known as the scarpus fascia, and the membranous layer of the superficial fascia of the urogenital triangle is also continuous as a sheath over the penis and the clitoris. Okay. So, sorry for the blurry picture. When I was making this PowerPoint, medyo klaro man yan, but ewan ko ba't naging ganyan ngayon. So the urogenital triangle has two pouches, no? The superficial pouch and the deep perineal pouch. Okay. Now, across the rami, across the yung lateral surface of the yung ischiopubic rami, no, we have three membranes, no? Three membranes traversing the two ramis. First, it's the superficial fascia. Don't worry, we have a clearer picture in the next slides. Okay, we have the superficial fascia of the urogenital diaphragm, the blue one. We have the inferior fascia of the urogenital diaphragm, which is also known as the perineal membrane, the second one, and the membranous layer of the superficial fascia, the one that I mentioned earlier, no, or the collis fascia, no? The third one. Between these three membranes are the pouches, the deep pouch or the deep space, and the superficial pouch. Can you see my cursor? Can you see my arrow, guys?
Yes,
Yes, Doc.
Yes, Doc.
Okay, next slide. So, ito na mas klarong picture, no? First line, second line, third line. Superficial fascia, inferior fascia, superior fascia, inferior fascia or perineal membrane, and the membranous fascia, no, of the superficial fascia. So 1, 2, 3. So the deep pouch and the superficial pouch. So the superficial perineal pouch is the space between the deep membranous fascia and the perineal membrane. No, So the boundaries, just read on this, okay? Masyado importante sa akin yun. Now, the contents of the superficial perineal pouch in males include these 12, no? The bulbus spongiosus, issue cavernosus, the transverse perineal, and the rest, and a whole lot more. So it also includes the root or the bulb and the crura of the penis, and the associated muscles, namely the issue cavernosus and the bulbus spongiosus, no? It also includes the bulbus or the proximal part of the spongy urethra, as well as transverse perineal muscles and pudendal vessels and nerves. Okay, so familiarize yourself with this structure here. Now, we will just discuss a couple of the contents of the superficial pouch, no, namely the muscles, the bulbus spongiosus, the issue cavernosus, and the superficial transverse perineal muscles. The bulbus spongiosus muscles, as you can see in the picture, okay, is situated on each side of the midline. This is your midline. It's situated on each side, no? The bulbus spongiosus muscle. It covers the bulb of the penis and the posterior aspect of the corpus spongiosum. It functions to compress, no, the penile part of the urethra and empty it of urine or semen. So it is the one that compresses, no? The anterior fibers of this muscle also compresses the deep dorsal vein of the penis. You can't see the deep source kasi ventral side tayo, impeding the drainage of the erectile tissue, thus assisting in the erection. So it's this muscle again that compresses the vein. Later on, we will talk about the erection part, okay? These muscles also is supplied by the perineal branch of the pudendal nerve. Now, these three muscles are supplied, no? The bulbus spongiosus, the issue cavernosus, and the superficial transverse. Next muscle, we talk about the issue cavernosus muscle, which covers the crus or the crus of the penis on its side. Okay, this is the issue cavernosus muscle. It also compresses and thereby also assists in the process of erection. And finally, we have the superficial transverse perineal muscles. These transverse muscles, which lie in the posterior part of the superficial perineal pouch. And it arises from the ischial ramus on each side, and it inserts itself into the perineal body on the midline. Okay, this muscle actually fixes the perineal body on the center of the perineum. Now we mentioned the perineal body. What is the perineal body? The perineal body is also known as central tendon. No? It's a pyramidal-shaped fibromuscular mass in the center of the perineum. It is between the anal canal and the vagina, or the bulb of the penis for this lecture, no? But the bulb of the penis. It's essential for the integrity of the pelvic floor because it is the site of attachment of numerous muscles in the pelvic floor, namely the bulbocavernosus, the perineal muscles, superficial perineal muscles, libertal ani, and so on and so forth. So this is an important site of attachment of the perineal muscles. Now, for the deep perineal pouch in the males, we have it contains the membranous urethra, the sphincter urethrae muscle, the bulbourethral glands, the deep transverse perineal muscles, as opposed to that of the superficial pouch. Diba? We have the superficial transverse. No? Dito deep transverse naman. We have the internal pudendal vessels and their branches and the dorsal nerves of the penis. Now, the sphincter urethrae muscle is this band here, no, between the superficial fascial layer and the superior fascial layer and the inferior fascial layer. We have the sphincter urethrae muscle, which is the muscle that surrounds the urethra in the deep perineal pouch, no? So it arises from the pubic arch on both sides, no, and passes medially, okay, to encircle the urethra. Okay? Now, the sphincter urethrae muscle functions to compress, okay, the membranous portion of the urethra, and it relaxes during micturition when you void, no. So this is the bond. So when you are trying to hold your urine, your pee, no, this is actually what you compress, no. This is what you use the muscle of the sphincter urethrae. Next is the deep transverse perineal muscle, as opposed to that and the superficial perineal muscle. This is clinically unimportant. We have the bulbourethral gland, which is two small glands. Okay, two small glands on each side of the urethra. It is this black one, no? This black one. That lies beneath the sphincter of the urethral muscles that enters the penile portion of the urethra. It produces secretions to lubricate the penile passageway during sexual stimulation. We also have the internal pudendal arteries, dorsal nerve of the penis. Okay, internal pudendal arteries give rise to the arteries to the bulb, the crura, and the dorsal artery of the penis. Dorsal nerve supplies the skin of the penis. So ito ang contents, the more important contents of the deep perineal pouches. We're done with the anatomy of the walls, of the urogenital triangle in the males. Now we go to the specific organs in the male reproductive system. The major components of the system are the testes, the epididymis, the ductus deferens, the ejaculatory ducts on each side, the urethra, the penis on the midline. We also have accessory glands, which include the single prostate, a pair of seminal vesicles, and the bulbourethral glands, which we already discussed earlier. On the urethral part, I think the previous lecture of Dr. Gasso, he mentioned this already, so I'm not touching this much more, no? So let's just go straight to the other organs. First is the penis. The penis is the pendulous organ, no? So it suspends from the sides of the pubic arch. It contains the greater part of the urethra. So majority of the urethra is contained in the penis. It consists of the internal root, okay? The first part is the internal root. Next is the shaft of the penis and the glands of the penis, no? The root is the portion of the penis that is inside the pelvic cavity. The shaft is outside. It's between the glands and the root, and it's the longer part of the penis. And the glands is the head of the penis, which has many nerve endings. No? So study this picture. Now we also have a foreskin, which is the covering of the skin over the penile glands. Is actually the one that's removed during circumcision. Are we all good so far? Okay lang, everyone?
Yes, Doc.
Now, the penis or the root of the penis consists of the two crura. Okay, this is your crura or the crus of the penis, no? Which are the proximal parts of the corpora cavernosa, and this is attached to the pubic arch on its side, no? And the bulb of the penis, no? Which is the proximal part of the corpus spongiosum on the midline, no? The bulb of the penis, and is anchored to the perineal body or the perineal membrane, no? So the crus, the crura, and the bulb, no? Yun ang inferior part of the penis, no? The proximal part of the penis. Now, the body of the penis is essentially composed of 3 cylinders, no, of erectile tissue enclosed in a tubular sheet of fascia, known as the buccal fascia. Okay, the erectile tissue is made of 2 dorsally placed corpora cavernosa, which are proximal extensions of the crura, as you remember earlier, and the single corpus spongiosum, which is the proximal extension of your bulb, no? Is also noted at the ventral surface, no? So these are the 2 erectile tissues, your corpora cavernosa and your spongiosa. The urethra is actually in the spongiosa, no? Okay. At its distal extremity, the corpus spongiosum actually expands to form the glands of the penis, which covers the distal end of the corpora cavernosa. So the glands is actually made of the spongiosum, not the cavernosum, okay? On the tip of the penis, on the tip of the glans penis, is the slit-like orifice of the urethra called the external urethral meatus, no? So blood supply of the penis is the corpora cavernosa are supplied by the deep arteries of the penis. The spongiosum is supplied by the artery of the bulb. Now, in addition, there's also the dorsal artery of the penis. All of the above arteries are branches of the internal pudendal artery. Venous drainage is via the internal pudendal veins. Lymphatics. Lymph drainage of the skin of the penis is into the superficial inguinal nodes, and the deep structures are drained into the internal iliac nodes. No? So if you have infections in the skin of the penis, folliculitis in the penis, you may also see lymph nodes in your inguinal areas. No? Prominent palpable lymph nodes in your inguinal areas. Nerve supply for sensation is from the pudendal nerve at the pelvic plexuses. Now, the erectile functions are parasympathetic for excitatory functions and sympathetic for inhibitory functions. We will discuss the erectile functions a little bit more later. Next is the scrotum. The scrotum is an outpouching of the lower part of the anterior abdominal wall. It contains the testes, no? The epididymis, and the lower ends of the spermatic cord. So this is a diagram of the scrotum which is cut open, exposing the testes inside and the spermatic cord. Okay. Now this is a gross picture of the testes. It is divided on its surface by a raphe or midline structure known as the raphe. which continues downward to the undersurface of the penis. No? Each compartment of the scrotum contains one of the two testes and one of the epididymitis. No? Now, the midline raphe indicates the line of fusion between the two labioscrotal swellings, which was present during embryogenic development. These swellings remain separate in the females and form the labia majora. Okay. Now, the walls of the scrotum has the following layers. The first part is the skin, followed by the superficial layer, or superficial fascia. Next is the spermatic fascia, and finally we have the tunica vaginalis. Now, the first layer of the skin is the skin of the scrotum, which is thin, wrinkled, and pigmented, and forms a single pouch. It is slightly ridged in the midline, as we mentioned earlier, the raphe, indicating the line of fusion of the two lateral labioscrotal swellings. Next is the superficial fascia, which is continuous with the fatty and membranous layer of the anterior abdominal wall, as I mentioned earlier. No? The fat is replaced by smooth muscle, again, as I mentioned earlier, known as the dartos muscle. This is innervated by sympathetic nerve fibers and is responsible for the wrinkling of the overlying skin, okay? Especially when it's cold. Next is the spermatic fascia. No, this has three layers, no, which lie beneath the superficial fascia. These three layers are derived from the three layers of the anterior abdominal wall on each side. First layer is the external spermatic fascia, derived from the aponeurosis of the external oblique muscles. Next is the cremasteric fascia, derived from the internal oblique muscles. And finally, we have the internal spermatic fascia, derived from the fascia transversalis. And finally, we have the tunica vaginalis layer, which lies within the spermatic fascia and covers the anterior medial and lateral surface of the testis. Drainage of the scrotum from the skin and the fascia, including the tunica vaginalis, drains the superficial inguinal lymph nodes. Again, if you have infections in the scrotum, if you have folliculitis or wounds in the scrotum, you may see palpable lymph nodes in your inguinal regions. Now, inside the scrotum, we have the testis. It's an ellipsoid-shaped structure, which initially develops in the abdomen, no? and moves before birth into the scrotum. No? No, usually the left testis lies lower than the right testis. So this image, we have the testis, the epididymis, the pampiniform plexuses, so this mesh of a blue structure or venous structure, the ductus deferens, which carries the sperm, the artery, and the spermatic cord. Okay. Now the testis is covered by the closed sac of the peritoneum, known as the tunica vaginalis. Okay. Originally connected to the abdominal cavity. After testicular descent, this connection closes, leaving a fibrous remnant, no, in tunica vaginalis. We will discuss the connection later on. Okay. The testis is also covered by a fibrous capsule known as the tunica albuginea. Okay. Tunica vaginalis and tunica albuginea. The inner surface of the testis is a series of fibrous septa. No, these, if you can see my arrow, these are the fibrous septa that divides the interior organ into lobules. This is the septa. These pink structures are your lobules. Now, lying within each lobules are at least 1 to 3 coiled seminiferous tubules. Now, these seminiferous tubules are the site of spermatozoa production, no, in each testis. Now, these tubules are then connected, then open into the network of retitestis. Okay, these are the retitestis. These retitestis are then connected to the epididymis by the small efferent ductus. So, seminiferous tubules, septa, retitestis, okay, efferent ductus, and the head of the epididymis. Okay. So again, spermatozoa is produced in the seminiferous tubules. Okay. Now, lymphatic drainage of the testes are to the para-aortic lymph nodes. So if you have cancers of the testis or testicular carcinoma, you can do an ultrasound and look in the midline. You see the enlarged para-aortic lymph nodes in the midline, in this area, which are area of metastasis of the testicular cancer. And then go to the spermatic cord, which is a collection of structures that pass through the inguinal canal, no, to and from the testis. It begins at the deep inguinal ring at the abdomen, no, lateral to the inferior epigastric artery, and then ends at the testes. The structures that are within the spermatic cord include the vas deferens, the testicular artery, the vas deferens, this pink one, the testicular artery, the testicular veins or the pampiniform plexi or pampiniform plexuses, the testicular vessels, autonomic nerves, remains of the processus vaginalis, and the genital branch of the genitofemoral nerve, which supplies the cremasteric muscle. Next, we go to the epididymis, which is a single long coiled duct that courses along the posterolateral side of the testis. No? The tunica vaginalis covers the epididymis with the exception of posterior border or the recess between the epididymis and the testes. No? So this is your epididymis. We have a clearer picture in the next slide. This one now. Okay. So this is your head, which is attached again, as earlier, which is attached to the retitestis by efferent ductus. The head, then the long body, and the tail, okay, of the epididymis. It is nearly 20 feet long, so mahaba siya. Its length provides ample storage space for the spermatozoa and allows them to mature, no? So the epididymis is primarily functions as a storage, no? And also functions as absorption of the fluid and nourishing the maturing sperm. So when the sperm leaves the testes and goes to the epididymis, it's actually immature. So in the epididymis, dun sila nagmamature, okay? With nourishment coming from the epididymis. Okay, this is so epididymis is primarily the storage area for maturing sperms. It has two distinct components: the efferent ductus, which forms an enlarged coiled mass that sits on the posterior superior pole of the testis and forms the head, okay, of the epididymis, and the true epididymis, which is a single long coiled duct into which the different ductus all drain and continues downwards along the posterolateral side of the testis, and it is known as the body of the epididymis, and enlarges to form the tail of the epididymis at the inferior pole of the testis. Okay, so three parts of the epididymis are mentioned: okay? Head, body, and tail. Venous drainage of the testes and epididymis both are drained to the testicular veins, which emerge from the testes and known as the pampiniform plexuses. Now, when the pampiniform plexuses goes up, it becomes reduced to a single vein. No. Now, the right testicular vein drains into the inferior vena cava, and the left testicular vein joins the left renal vein. So, mag-iba sila ng drainage. No. Right inferior vena cava, left renal vein. Okay. Arterial supplies from the testicular artery, both of the testes and the epididymis. When you go to the ductus deferens, no. From the Latin word carrying away, or vessel that carries away. It's also known as the vas deferens. No? The ductus deferens is a long muscular duct that transports the spermatozoa from the tail of the epididymis to the ejaculatory ducts. No? So this is your vas deferens, this long structure. So we will trace the course of this vas deferens later on. Okay. The ductus deferens arises from the tail. No. Here, look at my arrow. The vas deferens arises from the tail of the epididymis and traverses the inguinal canal. Papasok na daan sa inguinal canal, okay, to the deep ring of the abdominal cavity. Umaabot siya sa abdominal cavity, no? And then it passes downwards, no, on the lateral wall of the pelvis, almost to the ischial tuberosity. And then it turns medially across. It turns medially, na? Nandito na tayo. It turns medially and crosses the ureter posterior to the bladder. This is your ureter, no? This one is your ureter. This is your ductus deferens, crosses posterior to the bladder, posterior to the ureter. And then it continues inferiormedially, okay, along the base of the bladder. This is your bladder, by the way. Along the base of the bladder, anterior to the rectum, okay? And when it goes to the midline, it is joined by the duct of the seminal vesicle to form the ejaculatory duct, no? So the ejaculatory duct is formed by the union of the seminal vesicle and the ductus deferens. The terminal part of the vas deferens or the ductus deferens is dilated, no, to form the ampulla of the vas deferens. Now, the ejaculatory duct, as I mentioned earlier, penetrates to the prostate gland and connects with the prostatic urethra. No? This is the ejaculatory duct. It is two one on each side. It is less than 1 inch in diameter, or in length, 2.5 centimeters long, formed by the union of the duct of the vas deferens and the duct of the seminal vesicle. Now, these ejaculatory ducts pierce the posterior surface of the prostate and opens into the prostatic part of the urethra, no? Close to the prostatic utricle. The function of this duct is to drain the seminal fluid into the prostatic urethra. Okay? So, seminal vesicle plus vas deferens equals ejaculatory duct. Now, the seminal vesicle are accessory glands again of the male reproductive system. It is paired, no? Lobulated organs about 2 inches long, lying on the posterior surface of the bladder. This is your bladder. This is the posterior side. These are your seminal vesicles. And these are your ductus deferens. This is your prostate. Okay? Klaro tayo dyan? So, on the medial side of each vesicle, this is your seminal vesicle. On the medial side lies the vas deferens, no? Posteriorly, the seminal vesicles are close to the rectum. Now, inferiorly, the seminal vesicles narrow and joins the vas deferens on the same side to form the ejaculatory duct. Okay? So, narrow to form the ejaculatory duct. Okay. Okay. So this is a sagittal picture, no, to give you a clear picture of the seminal vesicle. As I mentioned, it is close to the rectum. This is your seminal vesicle, by the way. So we don't see the ductus deferens here because it's in the medial side. Nasa likod siya nito. Nasa likod siya ng vesicle on this view. So the duct actually pierces the posterior part of the prostate, going to this part of the urethra, the prostatic part of the urethra, near the utricle. Okay, this is your prostate pala, by the way. Are we clear here? Okay, next slide na ako. Blood supply to the seminal vesicle are from the inferior vesicle and middle rectal arteries, venous drainage into the internal iliac veins. Now we go to the prostate. The prostate is another accessory organ of the reproductive system, which is unpaired, and it surrounds the urethra and the pelvic cavity. Your prostate, your urethra, and your ejaculatory ducts in the side. Okay? It lies immediately inferior to the bladder, above the urogenital diaphragm, okay? Posterior to the pubic symphysis, and anterior to the rectum. Okay? Prostate is shaped like an inverted rounded cone, okay, with a larger base and a narrower apex. So this is peculiar this is unusual for the prostate, no, because the upper part is actually the base and the lower part is the apex, no. Baliktad siya, no. The base is the upper part, the lower part is the apex, no, in masamaba. Okay, the larger base is continuous with the neck of the bladder, and the narrow apex rests on the pelvic floor. The inferolateral surfaces of the prostate are in contact with the levator ani muscles. No, these muscles cradle the prostate between them. Okay, base, apex. Okay. So the two, as I mentioned earlier, again, the two ejaculatory ducts pierce the upper part of the posterior surface of the prostate. So posterior surface of the prostate, and then open into the prostatic urethra. Okay. No, anatomic relation of the prostate. Superiorly, the base of the prostate is continuous with the neck of the bladder. No. Okay. The urethra enters the center of the base of the prostate. Inferiorly, the apex of the prostate lies on the upper surface of the urogenital diaphragm. No. The urethra leaves the prostate just above the apex. Now, anteriorly, the prostate is related to the symphysis pubis. Posteriorly, the prostate is closely related to the anterior surface of the rectum, the rectal ampulla, no? And is separated to the rectal ampulla by a rectovesical septum, known as the fascia of the non-VA. Okay? Fascia of the non-VA. Now, laterally, the prostate is embraced by fibers from the levator ani muscles. Okay? Let's review this diagram na lang later on. Okay? The structure of the prostate. The prostate is divided into two lateral lobes, one median lobe, one anterior, and one posterior lobe. Okay. So for your anterior lobe, the tissue lying anterior to the urethra, this is your anterior lobe, the small part here, no? This is your urethra in the midline, no? This is your anterior lobe. We have no glands here. It's only composed of fibromuscular tissue. Okay. Next is the median lobe. The median lobe is the cone-shaped region between the two ejaculatory ducts. Okay, if you can see my arrow, these are the two ejaculatory ducts. This is your median lobe. No? We have your lateral lobes, which form the main mass of the gland, no? The prostate gland. No? This continues posteriorly and separated in the midline by the urethra. No? This is your lateral lobe up to this point, lateral lobe up to this point. Finally, we have your posterior lobe, okay, this small part here, the posterior medial part of the lateral lobes. Okay, this is the one that's palpable when you do a rectal exam, direct rectal examination to check for your prostate. Ito ang nakakapa mo, the posterior part of the prostate. Okay, are we good so far? Blood supply of the prostate actually comes from the internal pudendal, the inferior vesicle, and the middle rectal arteries, and venous drainage are directly into the interior iliac veins, internal iliac veins. Lymphatic drainage of the prostates are into the internal iliac and sacral lymph nodes. So, innervation, parasympathetic fibers from the pelvic splanchnic nerves, and sympathetic fibers from the inferior hypogastric plexuses. Now for erection. It's in page 320 on your book, no? It's a paragraph. This is just a simple discussion of it, no? Simple summary of the paragraph, no? So for the erection of the penis, no, it starts with various sexual stimuli. When you see something, when you hear something, smell, sometimes thought, and tactile or touch would actually stimulate your senses. This would give off stimulus or afferent stimuli to your brain, to your CNS. So in turn, your CNS will give off efferent impulses passing to the spinal cord, no, to the parasympathetic outflow on the second, third, and fourth sacral segments, no. So parasympathetic outflow. This is predominantly a parasympathetic phenomenon, no. Now, in your sacral area, you have your parasympathetic preganglionic fibers, which then stimulates your inferior hypogastric plexuses. Okay. Now, arising from these plexuses are your postganglionic fibers. These postganglionic fibers then stimulate your internal pudendal vascular branches. No, these vascular branches are the ones responsible for the erectile tissues at the root of the penis. No. Now, stimulating the erectile tissues at the root of the penis promote gradual vasodilation of these structures, no, namely the corpora cavernosa. Okay, well, mostly the corpora cavernosa. Now, the corpora cavernosa becomes gradually engorged, no. So as the corpora cavernosa. Okay, this is your flaccid penis, no. If you can see the corpora cavernosa is way larger in this erect penis, no. Now, as your corpora cavernosa becomes gradually engorges, no, the draining veins, no, particularly the ones in the posterior part, are compressed to the fascia, no. This retards the outflow of the blood. So as the corpora cavernosa enlarges, or as your penis becomes erect, no, gradually erects, no, the draining veins are compressed. So it prevents the blood that builds up from going out, no, thereby maintaining your erection. Okay, that is the basic summary of the paragraph, no, of erection. So it's mostly a parasympathetic phenomenon. Okay, erection parasympathetic, ejaculation is sympathetic. Okay, so during increased sexual excitement, no, first what happens is the bulbourethral glands, which is one of your accessory glands, as I mentioned earlier, moistens the external meatus, no. And then continued friction on the tip of the penis, the tip of the penis, or the glands is full of nerve endings, no. So continued friction in this area will give up afferent impulses. Okay, these afferent impulses then causes a discharge along the sympathetic nerve fibers to cause the smooth muscles of the epididymis, the vas deferens, the seminal vesicles, and the prostate to contract. No. So sympathetic impulses cause these smooth muscles to contract in these areas, no, the areas I mentioned, thereby producing the sperm, no, pushing the sperm or propelling the sperm outwards, no, from the storage area, which is the epididymis, no. So magko-contract ang ductus deferens, So lalabas ang sperm here. Then when it reaches the seminal vesicle again, seminal vesicle together with the ductus deferens will contract again, propel the sperm into the prostate. Then the smooth muscle in the prostate will contract again, propel the sperm into the penis. Now in the penis, the prostatic secretion, the sperm secretion, the spermatozoa or the sperm cell joins the penile and bulbourethral gland secretion in the penis. No, now it is ejected from the penile urethra due to rhythmic contraction of the bulbus spongiosum muscle. But this is the muscle that contracts to eject your urine as well as your sperm cell as well, no, or your semen. Now, during this contraction, the sphincter of the bladder contracts also, preventing the sperm cell to go up to the bladder. No? So, pagpasok niya dito, this contracts. Okay? So, pagpasok niya dito, hindi siya makaakyat doon. So, all antegrade flow of the sperm going towards the penis. No? This is primarily a sympathetic phenomenon at the T1L2 outflow. Now, for those of you who have not seen a sample of a sperm or semen before, this is whitish in origin, in appearance, no, liquid and jelly shape, jelly texture. Okay. Now we are done with the organs. We now go to the common pathologies. No, we will discuss few common pathologies of the male reproductive organs, starting with that of the prostate or the benign prostatic hyperplasia. An enlarged prostate means that the gland has grown bigger. Prostate enlargement happens to almost all men as they get older. So this is mostly happening in older individuals, no, older males. An enlarged prostate is often called the benign prostatic hyperplasia. It is not automatically cancer, no. And BPH does not raise the risk for prostate cancer. Symptoms of BPH include dribbling at the end of urination, inability to urinate or urinary retention, incomplete emptying of your bladder or urinary incontinence. You also feel need to urinate 2 or more times during the night. You also pain during urination, or sometimes you see blood in your urine. Your slow or delayed start of your urinary stream. So if you notice your dads, no, your fathers, your lolos, pag umiihi sila, as they grow older, mas matagal, no? It's because of the delay or the slow start of the urinary stream. And then there's a sudden or strong urge to urinate with a weak urinary stream, no? This is a picture of enlarged prostate gland. You can see the widened urethra, the prostatic urethra in this picture in a normal prostate, which is compressed when you have BPH, no? Next is prostatitis. It is the inflammation or the swelling of the prostate gland, no? It can be very painful, but will often get better eventually if the underlying condition is corrected. So unlike other prostate conditions, which usually affects older men, prostatitis can develop in men of all ages, no? But commonly it affects men aged 30 to 50. There are 2 main types, no? Chronic prostatitis and acute prostatitis. Now, chronic prostatitis is the one that comes and goes over a period of several months. The most common type is not usually caused by an infection. The acute prostatitis is where your symptoms are severe, no? And it develops suddenly. And it's serious and requires immediate treatment. Symptoms of prostatitis include a severe pain around your penis, your testis, your anus, abdomen, lower back, and you also have urinary symptoms. Sometimes you see blood in your urine. You also feel urinary retention. You also have aches and pains in your body, possibly fever. Sometimes you will see discharge, which come out of your penis. There is enlargement or tender prostate on rectal examination, and erectile dysfunction sometimes occur. Again, with an inflamed prostate, no, the prostatic urethra is compressed again, producing your urinary symptoms again. Okay, aside from the pain. Now, before I discuss on the next couple of abnormalities, no, namely the fluid and the hernia, no, hydrocele and the hernia, let me first discuss briefly the inguinal canal. This will be discussed a little bit more when you talk on when you have your lecture on the anterior abdominal wall, no, the development of your inguinal canal. But for purposes of to show you the descent of the testes na lang, we will touch on it briefly na lang, no. So, di ba, I mentioned earlier, originally, the testis it's located in the abdomen when the baby is during the fetal period, no. The testis is in the abdomen. Now we have your processus vaginalis, which is an invagination of the parietal peritoneum or an outpouching or invagination of your parietal peritoneum, no? And the gubernaculum, which is a fibromuscular ligament connected to the testis, no, from the outside surface, no. These two play major roles in the development of the inguinal canal, no. At 7 weeks, okay, 7 weeks, the gubernaculum, which is mesenchymal tissue, has developed. In male embryos, the cranial or the upper part of the gubernaculum is attached to the inferior pole of the testis, no. This is your gubernaculum. Follow my arrow. And the lower part, or the caudal part of the gubernaculum, is attached to the labioscrotal fold externally, no, on the surface. The gubernaculum assists in the descent of the testes, no, from their intra-abdominal position into the scrotum. Now, the gubernaculum passes through the anterior abdominal wall at the area of the site of the future inguinal canal. So, wala pang inguinal canal, nadaan na ang gubernaculum. Now, at 7 to 12 weeks of gestation, the gubernaculum contracts or shortens, no, then pulling the testis to the level of the deep inguinal ring, no? Deep inguinal ring. Now, at this time, the processus vaginalis or the PV now invaginates or becomes an outpouching, no, forms a pouch through the anterior abdominal wall along the path that was formed by the gubernaculum, no. The PV invaginates through the abdominal muscles, through the abdominal wall, along the path, no, formed by gubernaculum. Now, as it goes down, it gets extensions from the layers of the abdominal wall, and actually forms the wall of the inguinal canal, no. So the inguinal canal is composed of layers from the abdominal wall. Okay. At the 26 to 28 weeks, with androgenic stimulation, androgen produced by the testes, no, and with increased intra-abdominal pressure, the processus vaginalis, this one, the tercina tayo, the processus vaginalis, and the testis begins to descend and pass through the inguinal canal, no? Pass through the supposed area of the inguinal canal, no? Now, it takes 2 to 3 days from the testis to reach the scrotum during this stage, no? Now, at 32 to 40 weeks, the testis should be at the scrotum already. The inguinal canal has already been formed. Then the processus vaginalis becomes gradually obliterated, no? Downward gradual obliteration of the processus vaginalis just before birth, 32 to 40 weeks. No? However, the scrotal portion of the processus vaginalis remains patent and forms the tunica vaginalis. Di ba kanina we mentioned the tunica vaginalis a lot of times, no? It actually comes from the processus vaginalis. It's actually a remnant of the processus vaginalis. So dapat the connection between the abdominal cavity and the scrotal sac should be closed before birth, no? Dapat magsara sila. Now, kung hindi sila magsara, that's when problems arise, no? Normally, it closes, diba? This is your spermatic cord, this is your testis, this is your supposed area of your processus vaginalis, which was obliterated upon birth. Now, sometimes it doesn't close completely, no? It has an opening that is enough for fluid from the abdominal cavity to seep through. So when the baby is born, we see fluid within the scrotum, no? This is known as the congenital hydrocele, no? Fluid, may dumadaan na fluid from the abdominal cavity to the scrotal space, no? And sometimes the defect or the processus vaginalis, the space is large enough to permit bowel to go through, no? Sometimes hindi lang fluid. The space is large enough to permit bowel to go through, whether incompletely or completely. This is known as your inguinal hernia, no? Complete hernia, inguinal hernia. So yan ang problema. If the processus vaginalis becomes patent, it could lead to seepage of fluid or exit of bowel into this area, no? And sometimes, although rare, the proximal part of the processus vaginalis closes. The distal part closes. However, the middle part is retained and is filled with fluid. This is now what we call the hydrocele of your cord. This is very rare. I've not seen a sample of this. But hernia is very common, particularly the indirect inguinal hernia. No, this is the most common form of hernia. It is believed to be congenital in origin, as I discussed earlier, because of the patent processus vaginalis. Now, the processus vaginalis is the sac of the renal. The renal sac is the remains of the processus vaginalis. No, the indirect inguinal hernia enters inguinal canal through the deep inguinal ring. No, and it may extend part of the way along the canal or as far as the superficial inguinal ring or as far as the scrotum. No, pwedeng umabot sa scrotum yung bowel loops actually. No. Next is the hydrocele. Diba, in newborns, when the baby is born and the processus vaginalis is slightly patent, you will see fluid here. No, this is what you call congenital hydrocele, or also called as the communicating hydrocele. But sometimes, especially in older people, hydrocele also develops. No, also called the non-communicating hydrocele. Hydrocele is an accumulation of serous fluid in the body cavity. So for this lecture, it's an accumulation of fluid around the testis. No, hydrocele of the testis is often caused by fluid secreted by the tunica vaginalis. No, now primary hydroceles may develop in adulthood, particularly in the elderly, and in hot countries. No, by slow accumulation of serous fluid. No? So ito, one cause of primary hydrocele is when it's hot. No? This is presumably caused by the impaired reabsorption, which appears to be explanation of most primary hydrocele. And hydrocele can also be a result of a plugged inguinal lymphatic system caused by repeated chronic infection. No? So infection can cause hydrocele, or pwede rin parasites such as Wuchereria bancrofti or Brugia malayi, no? Which are mosquito-borne parasites. This condition, which would be a part of a more diffuse sequela known as elephantiasis. No? Diba, you have seen cases of elephantiasis, lumalaki yung lower extremities, no? Including the scrotum. No? This is due to blockage or plugging of the inguinal lymphatic system. Okay. Are we clear, guys? Okay pa kamo?
Yes po, Doc.
Cricoidism. It is also known as the undescending testis or absence of one or both testes from the scrotum. Now, a testis is absent from the normal scrotal position. Maybe one, it may be anywhere along the path of the descent. No, pwedeng dun sa high in the retroperitoneal. Pwede pa siyang, it could be still in the abdomen or high in the posterior retroperitoneal abdomen, or it could be in the inguinal canal. Okay, or it could be ectopic. No, having wandered from the path of descent, usually outside of the inguinal canal. No, sometimes even under the skin of the thigh. No, sometimes you can see the scrotum under the skin of the thigh. No, sometimes it is hypoplastic, or sometimes it's missing. So the different causes of an absence of the testis in the scrotum. Undescended testes are associated with reduced fertility, no? Because it's in the book. For the normal sperm to develop, it has to be it requires optimal temperature. No, that's why it hangs in the testis, because when it's up in your abdomen, it's medyo mainit sa loob. That's why it has to hang. So for testes that are descended, nasa loob sila ng abdominal cavity, it's exposed to higher temperature, so there's reduced fertility. So undescended testes are associated with reduced fertility. Mas mainit sa loob ng abdomen. There's also increased risk of germ cell tumors and psychological problems as the boy is grown. No? Undescended testes are also more susceptible to torsion. No? So without an intervention, undescended testicle will usually descend naman during the first year of life. Now, but to reduce this risk, undescended testes can be brought into the scrotum by a surgical procedure called orchiopexy. Okay, pwede siyang hatakin during the first year of life if it fails to descend. No? Next is varicocele. No, I mentioned earlier the venous drainage of your epididymis and your scrotum are known as the testicular veins or the pampiniform venous plexuses, no? Now, varicocele is an abnormal enlargement of your pampiniform venous plexuses, no? Okay, we're almost done. May message na ako. We're almost done. This is last 2 slides. This plexus of veins drains blood from the testicles back to the heart, no? So varicocele occurs in 15 to 20% of men. It's most common on the left, no? Most common on the left side of the scrotum. This is mainly due to because the left side of the scrotum drains to the left renal vein, which is more of high pressure compared to the right side of the scrotum, which drains the internal inguinal iliac vein. Sorry, internal iliac vein. Okay, this is my last slide. This is just an analogy of your sexual anatomy between males and females. For the glands in the males, its corresponding organ in the females is the clitoris. Your foreskin is your clitoral hood. Your shaft of the penis is your labia minora in the females. Your scrotal sac is your labia majora, and your testis is the ovaries. Okay, I guess that's it, no? Thank you, guys.
Thank you, Doc.
Thank you, Doc.
Thank you po, Doc.
Thank you, Doc. Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.